Welcome back to the Deep Dive. This is where we take your notes, your sources, and really turn them into high-yield knowledge, the kind that sticks.
Exactly.
And this deep dive is for you, the listener. We're using the revision notes you shared on, well, a really critical topic, post-exposure prophylaxis, PEP, for viruses like HIV, HBV, HCCV.
Really vital area.
Our mission is simple. Cut through the dense text, make it memorable, make it clear, using your material. So let's get into it.
Absolutely. And it's so important because, these decisions often have to be made incredibly quickly. The stakes are definitely high.
Right.
So understanding PEP, it's not just theory. It's about knowing what to do right now. We'll focus on the essentials from your notes, what it is, why timing matters so much, and the key details you absolutely need for revision.
Think of this as your custom audio guide straight from your notes.
Okay.
Okay, so first things first.
Yeah.
What exactly is PEP?
Okay, so post-exposure prophylaxis. It's basically an emergency medical step. You use specific medications after you think you've been exposed to something like HIV or Hep B or Hep C.
After the exposure.
Yes, after. And the whole point is to stop the infection before it properly takes hold. Your notes mention this covers both occupational exposure, workplace stuff like needle sticks in healthcare.
Yeah, the classic example.
And also non-occupational exposure, things like sexual contact or maybe sharing needles.
So you're trying to intercept the virus, get ahead of it, and your notes hammer home the speed aspect.
Yeah.
Why is starting ASAP so crucial?
That's really the core principle. The science, the pathogenesis studies, they suggest there's this limited window of opportunity.
Right.
Yeah, right after the virus gets into the body, but before it's had time to really start replicating everywhere, before it establishes that systemic infection.
Okay.
So starting PP super quickly, ideally within hours, and definitely, as your notes say, within that sort of 48 to 72-hour limit that's aiming to block the virus right at the start, stop it spreading.
Block that replication.
Exactly. And your notes confirm the evidence really points to maximum effect if you start quickly. Then you usually continue it for 28 days, a full course.
And the evidence base.
Well, the strongest initially from occupational studies, those healthcare exposures, but the data supporting it for non-occupational settings is definitely growing.
Right. Makes sense. Catch it before it sets up shop. So the urgency is tied right into that early infection stage. But it's not like every single exposure gets PP, is it? How do you decide who needs it?
No, definitely not automatic. It absolutely needs a quick but careful risk assessment. You have to weigh up what happened, the potential risks.
Against the treatment itself.
Yeah, because PP, as we'll get into, it has its own challenges, side effects and things. So risk assessment first.
Okay, let's dive into that assessment then. Starting with occupational exposure seems like a big focus in your notes. What types of exposure are we talking about?
Your notes list 3 main routes in a work setting. There's percutaneous injury, that's your needle stip or a cut from something sharp.
Okay.
Then there's contact with mucous membranes, so splashes into the eyes, nose, or mouth. And finally, contact with non-intact skin, so skin that's already broken, maybe scraped, or has dermatitis, or an open wound.
And is the risk the same for all those?
No, your notes make it clear there's a hierarchy. Percutaneous injury, the needle stick, that generally carries the highest risk. Then mucous membrane exposure. And non-intact skin contact is usually, much lower risk.
Got it. And the fluids? Is it just blood we worry about?
Blood is definitely the highest risk, yes. But your notes list quite a few others considered potentially infectious if there's a significant occupational exposure.
Such as?
Let's see. Amniotic fluid, CSF, exudative fluid, like from burns, breast milk, pericardial fluid, peritoneal, pleural. Saliva, but specifically in dentistry where it might have blood. Semen, synovial fluid, unfixed tissues or organs, vaginal secretions. And this is important. Any other body fluid if it's visibly stained with blood.
Wow. Okay, so it's a wider list than just blood. Good to remember. What about the injury itself? Does, how deep the needle went matter?
It does, yeah. The severity matters. Your notes list things that increase the risk quite a bit. Like if the injury was deep,
Makes sense.
or if the needle or whatever was visibly contaminated with blood, or if the procedure involved placing something in the source patient's vein or artery. And hollow bore needles are riskier too. They can transfer more fluid.
Right. And then there's the source patient, obviously crucial. What do the notes say about their status, especially viral load?
Absolutely critical factor. The risk goes up if the source patient has a higher viral load, or if they're in a more advanced stage of HIV, or potentially if they have drug-resistant virus strains.
Okay.
But here's something really interesting your notes point out. A real shift in thinking. It's about source patients with an undetectable viral load. defined in the notes as below 200 copies per ml.
Okay. Undetectable. What's the shift?
Well, previously, the guidance was not to recommend PP in that specific situation. Undetectable source, no PP needed. Now, the guidance says PEP should still be offered if the exposed person is anxious about the risk, even with an undetectable source.
Wow. So anxiety is now part of the calculation.
It seems so. It really shows that risk isn't just about the clinical probability. It's also about the psychological impact on the person exposed. That's a key point for revision.
Definitely. Okay, let's switch gears from occupational to non-occupational exposure. Sexual contact, sharing injecting gear. How's the risk assessed there?
Yeah, this can often be trickier. You might not have as much info about the source person or exactly what happened, but the risk varies a lot depending on the type of activity.
How so?
Your notes actually list the risks for sexual contact in descending order. Blood transfusion is technically highest risk listed, though probably less common for triggering PEP these days.
Right.
Then comes receptive anal intercourse. That's the highest risk sexual act listed, followed by receptive vaginal intercourse, then insertive vaginal, then insertive anal, and finally, receptive oral sex, specifically fellatio.
So receptive anal is top of the sexual risk list there.
Correct. It reflects how easily the virus can be transmitted through different types of contact, and other things matter too, beyond just the act itself.
Like what?
Like the infected partner's viral load, obviously, how common HIV is in that community, and host factors. Does the exposed person have other STIs? Or for vaginal sex, is menstruation happening? Things like that.
Okay. And your notes ask, when is PEP likely to actually work in these non-occupational situations? What criteria do they list?
Right. It lists 4 key things for likely effectiveness.
Yeah.
If the transmission risk from that specific exposure was high, if the exposure is unlikely to happen again regularly, if PP started really quickly, and if you expect the person will actually take the medication, properly good adherence.
Makes sense. And you mentioned specific BHIVA recommendations in the notes. Can we run through those? When should PPE be given after sexual exposure, according to that guidance?
Okay, based on the BHIVA guidance in your notes, PP should be given after receptive anal sex, insertive anal sex, receptive vaginal sex, and insertive vaginal sex, assuming the source person is known to have HIV.
Okay, should be given for those. Where is it should be considered?
It should be considered after fellatio with ejaculation, or if semen gets splashed directly into the eye.
Right. And just as vital for revision, where is PEP not recommended by BHIVA?
According to your notes, PEP is not recommended after fellatio without ejaculation or after cunnilingus. Knowing those specifics, the should, consider, and not recommended, that's definitely high-yield stuff.
Absolutely. And to help frame these risks, your notes give those percentage estimates for a single needle stick. Can you remind us of those?
Yeah, they're useful for comparison. For one needle stick, hepatitis B risk estimate is 20–30%.
20 to 30%. That's high.
It is much higher than the others. Hepatitis C is way lower, 0.52%, and HIV is the lowest of the 3, around 0.3%.
Okay, so Hep B is really up there. A good way to remember might be the order. B, then C, then HIV. And the rough size? Tens of percent for B, single percent for C, less than 1% for HIV.
Exactly. That BC-HIV order and remembering tens, single, sub 1%, that's a great memory hook. Like B for big risk, C for considerably less, H for hardly any, relatively speaking.
Perfect. Okay, so we've assessed the risk. We've decided PP is indicated. What are the actual drugs involved?
Right. So for HIV PIP, we use antiretroviral drugs. These are the same types of medications used to treat people who already have HIV.
Okay.
But, and this is an important point from your notes, none of these drugs are actually licensed specifically for PP. So when we use them for prevention like this, it's technically off-label use.
Ah, right, off-label. And the notes mention different classes of these drugs.
They do. NRTIs, nucleoside reverse transcriptase inhibitors, NNRTIs, non-nucleoside reverse transcriptase inhibitors, and PIs, protease inhibitors.
Yeah.
Basically, NRTIs and NNRTIs mess with the virus's ability to copy its genetic code,
Yeah.
while PIs stop it from assembling new virus particles. Now, your notes mention the standard DH recommendation. It's a combination pill called Truvada that contains 2 NRTIs, tenofovir and emtricitabine taken once a day, plus another combo pill, Kaletra, which has 2 PIs, lopinavir and ritonavir, taken twice a day.
Okay, Truvada plus Kaletra. But the notes also flag up a preferred regimen, right? From the Expert Advisory Group for AIDS.
Yes, exactly. And this is important. The preferred regimen now is raltegravir, that's an integrase inhibitor, different class, stops the virus integrating its DNA into the host cell, taken twice daily, plus that same Truvada pill once daily. and again for 28 days.
Raltegravir plus Truvada. Why is that preferred over the Truvada plus Kaletra combo?
The main reason highlighted in your notes is tolerability. Raltegravir is generally much easier for people to take than Kaletra, fewer side effects.
Oh, okay.
And the thinking is if it's better tolerated, people are much more likely to stick with it for the full 28 days. Better adherence should mean, better effectiveness. And your notes mention there aren't major safety issues holding it back either.
So, easier to take means more likely to finish the course, means potentially better results. Makes sense. Can this regimen be changed once someone started?
Yes, the notes say the drug choice can be reviewed, especially if you get new information about the source patient later on, like maybe potential drug resistance.
But the key message is,
Don't wait. Do not delay starting PEP just because you're waiting for info on the source. Start the preferred regimen. You can adjust later if needed. And there are also specific things to consider if the person exposed is pregnant.
right. Okay, so that's what. What about the how? The notes stress the process, protocols.
Absolutely. Speed and clear protocols are vital. Your notes emphasize that PEP needs to be started based on agreed local policies. It's not just, wander into any clinic.
Needs structure.
Definitely. Needs 24-hour access to expert advice, maybe occupational health, maybe A&E, maybe an on-call specialist. You need clear ways to get advice quickly on the risk level and the right drugs. Protocols should spell out who does what and how fast.
And the notes mention GPs possibly initiating it sometimes.
Yeah, they give an example like a GP looking after someone dying at home with HIV, and maybe an exposure happens there. But the point is, access to advice, the meds, the testing, it all needs to be defined in local protocols.
And a really practical point for everyone listening, staff education.
Crucial. Your notes highlight this. Making sure all the relevant staff know the local policy, know about prevention, and know exactly what to do and who to call immediately if an exposure happens. That avoids delays when people are stressed.
Good point. Now, we mentioned tolerability being better with the preferred regimen, but side effects are still a thing, right?
Oh, definitely. Your notes are clear on this. About half, 50% of people on PP get significant side effects.
Half. Wow.
Yeah, and it's serious enough that around 30% actually stop taking the medication early because of them.
30% stop early. That's significant.
It really is. Nausea is singled out as being very common, and it absolutely needs to be managed proactively. Treat the nausea to help people stay on the drugs.
Okay, those adherence challenges are real then. So someone's started PT, hopefully managing the side effects. What's the plan for monitoring and follow-up?
Your notes outline this pretty clearly. For checking if HIV infection happened, the main test is an antibody test using EIA, that's enzyme immunoassay.
Antibody test. Okay.
And the notes specifically advise against using direct virus tests like PCR for the initial diagnosis here. Seems they can give false positives sometimes in this post-exposure context.
Right. And when is the testing done?
Typically, it's 12 weeks after the exposure happened. Or, and this is key, at least 12 weeks after the person finishes the 28-day PP course.
Got it. So 12 weeks after exposure or are 12 weeks after stopping PP, are there times you need to monitor for longer?
Yes, your notes list some exceptions where longer follow-up is needed. If the exposed person has a weakened immune system.
Immunocompromised.
Right. Or if they develop symptoms that sound like acute retroviral syndrome, that sort of flu-like illness you can get early on with HIV. Or, importantly, if the source patient had both HIV and another virus, like hepatitis C.
Co-infection. Why is that important?
Because your notes mention a specific documented case where someone took longer to test positive for HIV-delayed seroconversion, out to 7 months after a sexual exposure where the source had both HIV and Hep C.
7 months. Okay, that specific case really flags why you need longer follow-up with HIV, HCV co-infection in the source. Definitely one for the revision list. What about monitoring the person taking PEP for drug side effects?
Yes, baseline tests are recommended before starting or very soon after. Your notes list, a full blood count, FBC, urea and electrolytes, UNEs for kidney function, and liver function tests, LFTs. Just checking the drugs aren't causing problems with blood cells, kidneys, or liver.
Okay. And your notes mention that actually getting people to come back for these follow-up appointments can be an issue.
Yeah, it seems attendance can be poor, based on one audit mention. But the notes also say that good counseling helps.
Counseling improves follow-up.
Apparently so. Counseling given when PPEP is prescribed seems to improve compliance with actually coming back for the tests.
And counseling is important for other reasons too, I assume.
Oh, absolutely. It's vital for addressing the emotional side, the distress of it all. Plus, providing clear education about the real risks, about how HIV infection develops, why PP is being offered, and safe sex counseling is crucial too.
safe sex counseling.
Yes, and interestingly, your notes bring up a study. Apparently, it found an increase in risky sexual behavior in some men who have sex with men after they'd finished a course of PEEP.
Wait, an increase in risk behavior after P?
That's what the study reported, according to your notes, which really underscores why that risk reduction counseling needs to be ongoing even after the immediate exposure is dealt with. It's not a one-off conversation.
That is a really striking point, definitely counterintuitive.
Yeah.
And what if, despite everything, PP doesn't work and someone does test positive?
Then the notes state clearly, prompt a referral for specialist HIV care and treatment.
Okay, so we've covered the whole journey, and your notes say PEP cuts transmission risk by up to 80%, which is good, but obviously not perfect. What reasons do the notes give for PEP failing sometimes?
Yeah, that 80% figure is often quoted. Your notes list several factors linked to failure. Starting PE too late is one back to that window.
The delay factor again.
Exactly. Also, a really large amount of virus being transmitted, a big inoculum. Exposure to HIV strains that are already resistant to the drugs being used.
Resistance strains.
Not finishing the full 28-day course short duration. Not taking the pills properly, non-adherence, which we know is tough because of side effects. And finally, host factors, just individual differences in the exposed person's body or immune system.
So a whole range of things can unfortunately conspire against it. The notes mention resistant strains being found after failure.
Yes, it notes that finding resistant virus after PP failure is rare, but the exact link between being exposed to a resistant strain in the source and subsequent PP failure. Well, your notes say that relationship isn't fully understood yet.
Okay, now the main focus has been HIV, HBV, HCV, but your notes do briefly mention post-exposure actions for a couple of other things, just to show the principle applies elsewhere.
Right, just briefly. For hepatitis A, it might be immunoglobulin, HNIG, or vaccine. For Hep B, it really depends heavily on the exposed person's vaccine history. Are they a responder, non-responder, still being vaccinated? And the source's status. Actions could be a booster dose, HBIG, immunoglobulin, more vaccine.
Very tailored for Hep B.
Very. For Hep C, there's no drug PP mention. It's monitoring with PCR tests monthly, and then treatment with interferon plus minus ribavirin if they do seroconvert. And for varicella zoster chickenpox virus, VZIG immune globulin is mentioned for specific vulnerable groups like pregnant women without immunity or immunosuppressed people.
So those just reinforce that post-exposure prophylaxis isn't one-size-fits-all. The agent and approach depend entirely on the bug.
Precisely. Different pathogen, different plan.
Okay, I think we have really unpacked your notes on PAP there.
Yeah.
We've hit the what and why, the urgency, how to assess risk, remembering those fluids, injury types, sexual acts, and that crucial point about undetectable viral load and anxiety. We covered the prescribing nuts and bolts, the preferred regimen, and why it's preferred.
The raltegravir and Truvada, yeah.
The side effect challenges, the monitoring schedule, those 12-week timings, the specific tests, and sadly, the reasons why it sometimes doesn't work. So pulling it all together for your revision, what's the takeaway?
I think it's about seeing the structure, remembering those risk percentages, BC, HIV, locking in the timeline, start ASAP, treat for 28 days, test 12 weeks after exposure OR after stopping PP, knowing those specific BHIVA sexual exposure recommendations, and understanding why that preferred regimen is preferred, better tolerability, better adherence. Hopefully this deep dive gives you that framework straight from your notes.
Absolutely. Now, we've spent this whole time talking about reacting after an exposure, emergency response, but your notes did give that little nod towards pre-exposure prophylaxis, PrEP. Thinking about prevention before anything happens, how might that shift in focus from emergency PPP to routine pre-PP for those at ongoing risk? How might that change the whole game for managing viral transmission, both in healthcare and out in the community?
That's a huge question. It really opens up the entire prevention landscape, doesn't it?
It certainly does. Something to think about. Well, that brings us to the end of this deep dive into post-exposure prophylaxis, all based on your revision material. We really hope this has helped solidify things for your studies.
Yes, absolutely. Best of luck with all the revision.
And don't forget, for more resources to help you prepare, do check out PassTheMSRA.com and FreeNTP.com. We'll catch you on the next deep dive.